everyone. I'm Mel Rose, and I'm the clinical manager for Lutherwood. And it's my pleasure to introduce Karen Leslie today. I got to hear Karen about a year and a half ago at a conference similar to this on the brain. And we had about 7 or 8 speakers that started early in the morning around 8:30 or 9 o'clock, and she was the last one.
On a Friday.
And
Yeah.
I was so impressed that she could engage all of us at like 3:30, 4 o'clock in the afternoon after all of these presentations. So I'm really delighted that Karen could be with us and that she accepted our invitation. Just to say a few words about Karen's credentials. She is an associate professor of pediatrics at the University of Toronto, and she obtained her MD from McMaster University, followed by pediatrics training at Queen's University and a fellowship in adolescent medicine at the Hospital for Sick Children. She also holds a graduate degree in health professional education from the Ontario Institute for Studies in Education at the University of Toronto. It used to be just OISE, but now it's connected to the University of Toronto. And Karen is also a staff pediatrician in the Division of Adolescent Medicine at the Hospital for Sick Children, where she leads the substance abuse program. One of the things I was really impressed about was the ability not only to present the science of the application. I think we're going to hear something about today. Welcome, Karen.
Thank you very much for sharing that information about me, Mel. So I just wanted to add a little bit of a disclaimer, a little bit more information about myself. So I want to be really clear that I'm not an expert researcher in adolescent brain research and substance use. What I actually really see myself as a knowledge user. I'm a clinician. I'm definitely involved in clinical research, and I've actually become very, very interested in this topic of adolescents, alcohol and substance use in the brain through over the last couple of years. I was asked to come and talk about it, and so when you're asked to do a talk, you start exploring the literature. And I think as was mentioned earlier this morning, in the last 10 years, the literature has exploded, right? And there are thousands and thousands of research papers. And so what I've really tried to do for this talk and for other talks I've done like it is to try to kind of distill some of that, to try to kind of put it together and make some sense of it, and then to try to be able to frame it in a way to think about, okay, so how does this inform the work that we do with the young people that we see? So what I'm really hoping to do is to kind of share with you kind of my thinking, some of the examples of some of the studies that have been done. It's not an exhaustive review of absolutely everything in the field, because I'd have to take a sabbatical to do that full time. But it is hopefully bringing you some information, building on what we've heard this morning. And then what I really want to do is have an opportunity to engage you into some discussion about, okay, so how does this, are some of these things you're already doing in the centers that you work in? How do you think about what I'm bringing to share with you this afternoon? So I've got some stuff to bring, but I really want to build on your experience and your thinking about this so that we can kind of put it all together and have more of a conversation or discussion about it. So I'm going to leave some time to talk about that. So I'm actually interested in knowing who you all are. So I'm wondering if we could just kind of go around and if you could just introduce yourself, where you work, and maybe just kind of a one line about kind of just the population of young people that you serve, just to say we have a sense of kind of are we sort of, my sense is we are working with similar groups, but just to give some sense of that. Okay. Right. Okay. Right. Okay. Mhm. Okay. Mhm. Right. Okay. Okay. Great. Great.
And definitely, I am the director of employment and health and facility services here at BrainLinks. And I've been in that role. Well, I've been in the employment division for the last 2 years, but prior to that, my career has been in health. So I'm just here as a general interest and to catch myself up on some of the research.
Mm-hmm. Great.
I'm John Murphy. I'm a program manager here at BrainLinks, and currently the program manager here for BrainLinks, which is with the overseeing the engagement of the employment division. So we work with these anywhere from 12 organizations and communities.
Okay. Great.
I'm Sharon Brady. I'm a social worker for Elizabeth. I work in the collaborative program we do with the Amelia with the endocannabinoid program. So I work with youth who are either involved or at risk of being involved with a lot of significant substance use for and I'm going to run commission with you as well. And I work in 2 different programs, one where doctors refer anyone of any age for counseling, and I got a number of adolescents in that program. I also supervise a program where we place social work interns who come to us within placement within high schools, and we have been dealing with a lot of issues of addiction and suicide.
And pretty much I'm the director of knowledge exchange and internet. So we're not a direct service provider, we're a service provider for service providers. So we work with practitioners who do work on the front lines of parents and help them to get linked up to most recent research evidence and making program evaluation and we're finding helping to find them.
Wonderful.
I'm Jeff Carter from NHS Services in London, Ontario, and I'm a psychologist and coordinator for quality improvement. And most of our services are 0 to 14, and we have a hospital development in development for that. And I'm interested in this area of that.
And there's program that represents issues of hospital, and the person from there is management of regulation team, as well as concurrent story program, and our functional health and opportunities for you and we're seeing real rise in the My name is Vicki Downey, and I'm a New Times working on Adolescent, and we're at the school quality program evaluation, quality assurance, and also supervise 3 of our residential managers and residential programs are adolescents and managers. So services and Torah, so Central Winnipeg, Thompson, and we serve over 65 compared to 70 more intensive services for kids, about 225 on a given day. And we also survey homeless youth population and substance abuse and something that's very evident in many of our youth. And they're really dealing with the mental health issues and just the distress and other things.
So an incredible diversity, incredible amount of expertise, and lots and lots of work with adolescents who have complex issues, with substance use being one of them, right? I think that's exactly the population that I work with as well. So what I'm hoping to do is advance the next slide. Whoops. Okay. So hopefully by the end of this session, you're going to be able to identify sort of in a general way what's known about the impact of alcohol and other substances on the adolescent brain, and to be able to discuss some of the implications of this research on kind of the different kinds of treatment considerations and approaches for adolescents and their families. So just to throw out a few numbers, and apologies to the non-Ontario folks, because this is from the Ontario Student Drug Use Survey. So 22% of all students, which represents over 200,000 students in Ontario, report binge drinking at least once in the past 4 weeks. Okay, so binge drinking, again, 5 or more drinks at one time. There actually are similar surveys done in other provinces. The methodology is a little bit different, but in actual fact, there's some remarkable similarities across provinces with a few regional differences. So most but not all provinces do similar surveys. Are people familiar with the Ontario Student Drug Use Survey? Okay, so it does survey young people in rural and urban areas. It's been done every 2 years for the past 30 years. So it's a great survey that actually allows us to track prevalence and look at sort of emerging issues in substance use. And like I said, it's this data, the next couple of slides come from that particular survey. So just to give us where we're at. About 2% of students in that survey report using cannabis on a daily basis, and that's the equivalent of about 23,000 students in Ontario, so use cannabis on a daily basis. About 1 in 6 adolescents in the most recent survey reported being drunk or high at school in the past year. Okay, so bringing in how do we really think about the different functions adolescents have, and how do we really think about how their alcohol and substance use may affect their learning and their academic life. This is just data, again, many of you are probably familiar with this. This is really just a snapshot from the most recent Ontario Student Drug Use Survey, which really just looks at past year use, and not surprisingly, lifetime use isn't a lot different, just because we're talking about a lifetime that's not really very long yet, right? This is grades 7 to 12, boys and girls included. So this is the whole group that responded. And again, I don't think too much of this is going to be a surprise, but just to point out a couple of things. So alcohol has and remains the most frequently used substance, and I think that's important, particularly when we talk to parents, because many of the parents I speak with are worried about all of the other drugs their kids might be using, and in actual fact, alcohol's probably got the potential to cause the most morbidity with adolescents compared to all of these other substances. So I say to parents, if you're going to worry about something, don't kind of go, oh, it's just alcohol. I'm more worried about them doing the hard stuff, and I hate the word hard soft, so please, I hope nobody uses those terms. But alcohol is right up there. Cannabis is now the second most used substance, and if we looked at this data about 15 years ago, it wouldn't have been. It would have been way down the list. Tobacco would have been the second most frequently used substance. So the good news is that tobacco use is way down. The not so good news is it's essentially been replaced by cannabis use, and I'll show you some numbers later on about that. We also, a few other trends, each year more things get asked. Non-medicinal use or misuse, NM refers to use of a prescription medication in a way other than it was intended, right? So the use of opioid pain relievers is way up there, and also when you think about it, combining those with alcohol is particularly problematic. So we certainly know that the use of non-medicinal medication, so prescription medication, is something, misuse is something that we really need to be concerned about. And then there's a smattering of kind of, pretty well almost everything you can think about. A couple of things to keep in mind about this data is that it's kids in school. It's a school-based survey, right? So it doesn't include young people who are on the street, young people who are in correctional facilities, young people who live on Aboriginal reserves, or kids that just don't go to school. And we know that those young people have much, much higher risks. You know, we did a survey of street youth a number of years ago, and 99% of them were using one or more substances, right? So this is teens who go to school. Now, about 18% of the teens in this survey screened in the concerning range on the CRAFT, which is a screening tool for problematic substance use. So we do know that within this overall school sample, there probably are about 15 to 18% of them who likely have problematic alcohol or substance use. But overall, they're a different group than that higher risk group that many of us see in our centers, in addition to this group. And again, this just shows us a little bit about the overlap. I think, as many of you know, I mean, it's rare for many teenagers to be only using one thing. So polysubstance use is very common, and that makes it very tricky just because of all the different kinds of interactions. But this just really kind of shows you about kind of the interactions. How many of those youth were using just alcohol, just cannabis, combinations of all of them, right? And you can see right in the middle there, there's about 5% of the cohort were using kind of everything. So I've got a couple of cases peppered through my talk, just for us to be kind of putting some context. And again, you may well have young people from your agencies that kind of jump into mind as I'm talking, but this is sort of a compilation of two cases that I've worked with. So Jeff, 16, recently had a suicide attempt where he ingested Percocet, Tylenol 3s, and alcohol. Not a good combination at all. He's got a history of irritable mood, insomnia, poor school performance, and this really all began after he experienced a concussion while playing hockey. And he hasn't actually been able to play hockey since, not taking any medications. He's been an okay student up until last year, started to skip classes. Right at this point in time, he only has several grade 9 credits, and really not doing very well at school. Drinks alcohol most weekends, usually 10 to 12 beers an evening, which allows him to kind of check out from how he's feeling. He also smokes cannabis on a pretty regular basis, and he's tried both ecstasy and ketamine. Does Jeff sound familiar? Is he sort of, for many of you, he's certainly a very typical young man that we might see in our program. So there are two pieces that I'm going to talk about in this session. One is really to reinforce actually a lot of what we've already heard. So we didn't get to see each other's slides ahead of time, but remarkably, I think there's some nice synergies with what you heard this morning and a few of the things that I'm going to highlight. So these two concepts. One is that adolescence is a time of vulnerability to the effects of alcohol and substances. And then the other is, what do we know about the impact of that alcohol and substance abuse on the developing brain, which really are sort of, I think, the two big areas of thinking about this. And I'm just going to start with this quote just because I found this and I really liked it. Teenagers blithely skip off to uncertain futures while their parents sit weeping curbside in the Volvo because the adolescent brain isn't yet formed enough to recognize and evaluate risk. I really thought that really, you can get this image instantly, right, of the disconnect between, parents and those of us who work with young people really, really just fearing for the young people that we work with and the kinds of things they're getting into, and yet that's in direct contrast generally with how worried young people are and how unable they are really to kind of appreciate some of the risk of some of the behaviors that they're engaging in. So when I tried to put all this together, there are these three, to me, kind of big buckets of areas to think about, and they're connected, but I couldn't come up with a way to really sort of describe them and connect them all. They really are all interconnected, but I'm not sure I haven't really seen, I tried to find, I couldn't really find a really great model that really puts these together in the way I wanted to. So I'm going to talk about them separately, but keeping in mind that they certainly interconnect, and based on the presentations this morning, we certainly have some sense of how those connections happen. So when I think about sort of the vulnerability of the adolescent brain to substances, there's the motivation and reward piece, there's the impulse control, and then there's this inability, really, to perceive risk, which I think are really kind of hallmarks of the adolescent brain and how it operates. And so we're thinking about these things in terms of how it relates to alcohol and substance use. So when we think about motivation and reward, we know that there is this hierarchy of needs, and when we think really a little about where are adolescents really focused in terms of the kinds of things that they identify as being motivation, things that they really see as rewarding, we definitely know that, and I think we heard this morning that adolescents respond differently with respect to peer interactions and pleasurable stimuli. So we know that adolescents certainly are very much driven by the need to immediate gratification, right? That what's going to get me in the moment. And and they may disregard all of what they know about kind of what the risks of that may be, because they're driven by that particular reward that's right in front of them that's going to make them feel good, right? And we know that if there are peers involved in that, and we saw that from the studies that were talked about just recently, but we actually know that if there's a social component to that behavior and that reward, that greatly ups the rewards in the eyes of an adolescent. So we certainly know that when substances are there and substances add to the pleasurable experience, that's going to be augmented by having peers around and having peers involved in that. And we know that much adolescent substance use is usually initiated in a peer context. So peers have a big influence on the initiation of substance use and also have a huge role in the reinforcement of it. And certainly in our program, one of the big strategies we work on with teens is how can you think about reconnecting with friends who don't use, right? Because the big problem is if you're trying to reduce or eliminate your substance use, all of a sudden you have no friends to hang out with because all of your friends are using. And so, one of the strategies to be looking at is how do you disconnect the peer relationships from the rewards that come with alcohol and substance use. So we certainly know that the rewards and motivations that adolescents get from substance use are greatly reinforced by their substance use in the context of being with peers. So in order to actually perceive something as being risky, there's kind of two things that you have to be able to do. You have to be able to identify that there is a particular consequence that is linked with a behavior. So if I do this, or if somebody does this might happen. And then you have to actually be able to apply the likelihood of that to yourself. And we do this a lot when we assess capacity in young people that come to our our programs. And is this young person able to, do they have the capacity to understand? And many young people can actually do this. They know, okay, having sex without a condom may lead to becoming pregnant. They can say that to you, right? Using, drinking a lot might be bad. Binge drinking could get me into problems. What they fail miserably on is the second part of this kind of test of capacity and the ability to appreciate risk is they kind of say, but it's not going to happen to me. I've had sex without a condom for the past month and I haven't gotten pregnant, or the past year and I've never gotten pregnant, right? In other words, it'll never happen to me, even though, yes, we know that the more often you have sex without a condom. So I think this is a really fundamental piece, and some of this is, I'm not sure that we can necessarily do anything about, because a lot of this is developmental, a lot of this is hardwired into adolescents' brains, that they don't have this ability to apply the likelihood of a consequence to themselves, but it is something that we do see developing over time. But it's a big piece in being able to look at both their ability and their ability to identify something as being potentially risky. And then obviously that links in greatly to this next piece, which is the impulse control, your ability to actually put on the brakes, right? And your ability, your judgment, that sort of hot cognition, right, that the speaker talked about yesterday. So that, you may actually be able to think that something's risky, but in the moment, that impulse is going to, is going to drive you. So that impulse control and the ability to put on the brakes or not plays a huge role in adolescents' vulnerability to substances. So it's really these three big areas of what we know. So when we think about the adolescent brain, there's sort of the structure of the brain, there's the function of it, and there's also kind of other kinds of things that go on in the brain in terms of pathways, in terms of neurochemicals. And so when I was thinking a little bit about it, those are the three areas, again, of thinking about how do we think about the adolescent brain in respect of substances. Some of you might have seen this. I kind of think this is a little bit of a different take on some of the brain models that you might see. I particularly like this one here, which is the love for parents with the disdain for parents, right? How many of you have teenagers at home or have had teenagers at home? Okay, all right. So you really, really appreciate the challenges with adolescent brains when you have one or more living in your house. But anyway, so certainly, we need to be understanding, what does the adolescent brain do, and how do we really think about it in order to kind of get some sense of where are we targeting kind of our interventions. So you saw this morning. So this is the real pictures of adolescent brains. And again, just to reinforce, so we we know that there's this area that's continuing to grow right up into the early 20s, right? And this to me is really exciting because a number of years ago, before we really knew this, I'd have an adolescent coming into my office and they'd be flagged from school and they'd be using marijuana on a regular basis. However, they were still doing okay at school. They weren't, they weren't being truant. They were coming home on time. No money was going missing at home. And the parents and the kid would be saying, well, like, why do you have to be worried about this? I'm doing fine. Like, there's no, why are you telling me I should use less marijuana because I'm functioning fine? And there was kind of like not much of a comeback that we'd have around this, well, potentially you could be developing some problems. And so I think this is really, to me, this has really given us additional information to be sharing with parents and young people to say, actually, you may not realize this, but potentially there's some things going on in your brain, and this is why. And so I think this has actually really been important, and it's very important that we think about creative ways to be able to share this information with young people and their parents. And I'm going to show you a little bit of an example of how we've attempted to do that later. So this is really exciting in the sense that we know that there's a vulnerability of the brain, but we also know that there's the opportunity of the brain to continue to grow into the 20s, which gives us an opportunity for intervention. So again, some of this is going to be review. So this prefrontal cortex is not that no part of your brain isn't important, but this is a very important part when we think a little bit about the impulse control, the reward system, and that ability to actually stop yourself, right, put on the brakes. And so attention, reasoning, planning, decision-making, impulse control, abstract thinking, like these are all really, really fundamental activities of the prefrontal cortex. And the adolescent is incredibly vulnerable because of that, because this is the area of their brain that is continuing to grow in adolescence. And this is the area that's very vulnerable to the effects of alcohol and substances. So I'm just going to tell you a little bit about Amelia, just to be thinking about another case. So this is Amelia. She's 14 years old, and she has, again, some depressed mood. So we know, I think many of you talked about concurrent disorders, right? So we know that 30 to 50% of young people presenting for a substance-related issue are going to have a concurrent mental health disorder, and the converse is true. And I would say, certainly in the program I work in, it's much, much higher than that. It's probably closer to 75, 80% in terms of them being co-associating. So she also has her father is a heavy drinker. She has a peer group who use a lot of substances, and so she's been experimenting over the past year and is now using cannabis daily and lots of alcohol on the weekends. She used to be very involved with dance and music, and she really hasn't been engaged with those things. And again, that's a pretty typical pattern where young people become much less involved with the other activities, and all of their activities become centered around using substances. She was sexually assaulted at a party last year. And since then, she's had increasingly poor self-esteem. She's been engaging in some cutting, and she's continuing to place herself in risky situations and continuing to drink excessively when she's at parties. And she's also become very distressed by peers' criticism about her being sexually promiscuous. So you can see how this kind of cycle kind of gets set up, this loop, right, which reinforces itself. So I'd said one of the things we have to think about is what are the vulnerabilities of the adolescent brain to the effects of alcohol and substance use. And so now I want to share with you a little bit of the data on what's the impact of alcohol and other substance use on the developing brain. And again, this is really just a sort of a smattering of kind of sort of some of the key studies that I think represent some of these issues. So one of the things to know is that we actually have a lot of what are called endocannabinoid receptors in our body. They're just natural. We actually have natural kind of cannabinoids in our body. So we actually have a lot of cannabinoid receptors in different parts of our brain, which then get affected by this exogenous or external cannabis that gets used. So we definitely know that the prefrontal cortex actually is one of those areas that has a lot of these cannabinoid receptors. So there actually is, there's an area that's kind of very primed to kind of be influenced by the effects of cannabis in particular. So when we look at sort of the structure of brains, there have been a number of studies, but this one particular study really showed that when they looked at adolescents with alcohol use disorder and compared them to age-matched controls, and I think this was a different study, I think, than it was alluded to this morning, but it's got a similar finding, that they actually had smaller prefrontal gray and white matter volumes compared to age-matched controls. and that actually correlated with the number of drinks per drinking episode. So you could say, well, how do you know it was actually the effect of the drinking? Maybe it's their brains were different in the first place, which actually caused them to be more likely to start drinking. But the fact that there was a dose effect suggests that it wasn't just that these young people had different brains to start with, and therefore that caused them to start drinking, but there may be some suggestion that in actual fact there was an association with the alcohol and with what they were drinking. Mm-hmm. And that's the question that actually has not been answered in anything I could find, So that one of the challenges is, I think what we probably all know for those of us who do research with this patient population is its longitudinal studies are so difficult to do just because it's very hard to kind of get them back, and it's almost impossible to control what they're doing in the before and after. So I haven't seen anything that's really looked at, tracking young people in this kind of study to say, okay, so if they stop drinking, what do their brains look like? If they continue to drink and past 20, is that an irreversible change? So I think those are absolutely the studies that need to be done. The other thing is that they're very small numbers, right? Like I think this study had 14 or 15 young people in it. And this will come up later as we talk about other studies. The other big challenge in a lot of this work is, definitions of substance abuse, and how much, right? Because, for example, for alcohol, they screened them with a validated tool. They used the audit, right, which is the Alcohol Use Disorders Inventory. So they did use the audit as an attempt to identify who would fall into that kind of problematic alcohol use disorder. So they tried to use a standardized. But other studies will just say, somebody who drank, that I think we heard this morning, somebody who had 5 or more drinks at least once in the past 3 months, right? And that isn't necessarily the same as young people who have an alcohol use disorder. So sometimes the definitions by which someone's considered to be, have an alcohol use, so it makes it very hard to kind of compare studies and to be able to get a sense of, okay, so how does this relate to the young people that I might be seeing? But certainly some suggestion that there's an influence on the actual structure of the brain as a result of exposure to alcohol during adolescence. So then looking more at sort of functional evidence. So this is looking at functional magnetic resonance imaging. And so these 2 studies looked at, the first study looked at attentional control with adolescents who were chronic cannabis abusers. Now again, the definition they used was using cannabis more than 100 days out of the past year, okay? I don't know whether that would be chronic cannabis, that could be, but what about young people who use cannabis every day? That didn't control for how many times a day. So again, this was adolescents who use cannabis at least 1 in 3 days in the past year. And they were able to, they definitely demonstrated on functional scanning that there was inefficient attentional control, again, as compared to a group who weren't chronic cannabis users. So there did seem to be some impact on what was happening in the brain as a result of their cannabis use. And then the other interesting thing was in this other consortium that has done a number of different studies, was that adolescents, and again, look at the language, it's all very different, right? Adolescents with potentially problematic substance use, like what does that mean, right? Use greater risk-taking as well as lower activation relative. So they didn't get the same kind of activation when they were exposed to other kinds of exposures. And that really suggested that they formed some of those patterns. We talked about sort of the plasticity stuff. So, this is an example where neuroplasticity is happening in a way you don't want it to happen, right? Because they've been developing some abnormal connections in terms of how they respond to different stimuli. And again, this was compared to age-matched controls who hadn't been using. So some evidence, again, that there's some functional things that are happening differently in adolescents' brains as a result of their substance use. The other thing I alluded to is these dopaminergic pathways, right? These pleasure pathways. And Nora Volkow, who's the head of the National Institute of Drug Abuse in the U.S., is a real passionate leader in this theory of addiction, representing kind of reward deficiencies. So then essentially this model here is for cocaine, but it can be for lots of things. So the idea is that we have these pathways that kind of are stimulated by rewards. They're reward pathways. We all have certain things that over time have become rewarding to us, right? For me, it's a great deal on a good pair of shoes, but for other people, it's going to be different kind of things. So we know that there are very common kinds of things that are rewards. that kind of cross everybody, sort of food, sex, sort of the kind of basic, when you think about the Maslow's hierarchy of need. What happens over time when people are actually using drugs of abuse, the drugs of abuse become what's actually triggering those dopaminergic pathways. And so in actual fact, you kind of rewire what actually gives you pleasure so that the things that used to give you pleasure don't anymore, and the only way that you can actually get pleasure is from engaging in using substances. And so that, again, we know that this certainly has been studied both in adolescents and also in adults in terms of one of the theories kind of addiction. And we actually know there's some studies looking, again, more specifically both from human models but also animal studies, again, suggesting, like we mentioned before, that for adolescents, that the value of drugs of abuse is influenced by social interactions, and so actually is more likely to reinforce those pleasure pathways, so that the adolescents have an increased vulnerability to those pathways that you really don't want to be developing in association with their substance use, as well as it happening in social context. So the social context augments the likelihood that that pleasure pathway is going to become the preferable one. And some of this explains what people often think about people who've actually been using substances and then have become abstinent over time, and then all of a sudden are in a setting, we talked sort of similar to the example around the trauma and the PTSD example, that there are associations. So they may actually meet up with somebody they haven't seen in a long time, but that person was somebody that they used to use substances with. And then before you know it, they've started to use again, because there's that connection, that social piece is in that memory in terms of that pleasurable pathway. So I put this picture up, and again, I don't have a way of how these all connect, but I think what it's really to reinforce, and again, I probably don't have to make this point with you, given your background, is that the adolescent brain is being influenced by so many different things, right? So, there's the concurrent disorders. We don't even really know kind of how does the adolescent who's got ADHD's brain look in addition to substances, and what their vulnerability might be to those prefrontal inattentive problems when they've already got an impulsivity or an inattentive problem. So how do concurrent disorders affect the brain, and all of these things that I've just told you about how alcohol and substances might be affecting the brain? The hormone, I asked the question this morning, we really don't have a good understanding. Most of these studies are looking at age. They don't look at pubertal stage, right? And we know that somebody who's 17 is going to be very different than somebody else who's at 17 in terms of their pubertal development and the effects that testosterone and estrogen might have on your brain and how your brain develops. So we need to be doing a lot more studies that actually involve pubertal stage and brain development and looking at vulnerabilities. And that may give you some practical advice, because then we can be taking that into consideration when we're thinking about where a young person might be at in their brain development, because it may not be that somebody at 18's brain is at the same stage of development as somebody else's brain at 18, but their pubertal stage might give us additional clues as to what their brain development might be. That might be a quick way for us to be able to make some judgments around brain development without having to scan their brains, right? Peers we've talked about. Environment obviously has a huge role to play, both in some of the epigenetics and some of the other things that we've talked about. Alcohol and substances themselves. Again, trauma, early childhood abuse, and the case I mentioned about the young man who had the concussion, right? We're just really beginning to look at the research in terms of the impact of concussions, and we know that many, many young people are involved in sports where they're being exposed and they're experiencing concussions. And we haven't really looked at where's the mix of that? Do we know that young people who've had concussions may be at increased risk to develop alcohol and substance use issues, right? We certainly have seen that in NHL hockey players, or in athletes who've had significant substance use as a result of the picture they've had after a series of concussions. So I think there's lots of room for research in that area. And then, layered on top of all of these other things, are kind of these base kind of fundamental characteristics of adolescents, in that they're risk takers, they're not great judges of the risk of in terms of risk decision making, they're novelty seeking, they look at those pleasurable words, and I think all of us know they're incredibly egocentric, right? So it's all about you and what might happen for you in the moment, not what happened to you later, or not what might happen to somebody else. And so all of these things, I think that's what makes this very messy, right? We can be looking at all these studies, we can be learning what some of these very controlled studies with certain groups of young people can be showing us, but then we have to be taking it back out and thinking about, okay, how does this fit with this young person who has had a concussion and has a concurrent mental health disorder and has been abused and, right? So I think that's where that evidence, application of knowledge we need to be thinking about. So how do we think about some of this in terms of treatment? And again, I seem to like threes for this presentation because I've sort of thought about this in 3 different areas. And again, some of these have come up already in what we've been talking about in this session. I want to start with this because I think, to me, this is really sort of the biggest challenge in working with young people with substance use is that, so I'm sure they're all familiar with sort of the stages of change model. And, certainly in the young people I work with, they're here, right? You are here, right? And I think that's a big challenge in most kind of illnesses in life. People kind of go, yes, I have this problem, I need to go and get help, right? How many of you on a regular basis have teenagers coming to your program saying, I have a substance use problem, I need help? Yeah, very, very. And so to me, that's the $1 million question, right? Is, what are some of the strategies and how can we use what we know about this brain research to be really thinking about, how do we get somebody from here to kind of in here, right, an adolescent, when clearly everybody else thinks they need to except for them, right? And so I think some of this research is going to help us a little bit on that. So the 3 areas that I'm going to touch on, and then I'd love to have a conversation with kind of how is this working in your centers, and how do you see this working? One is around, so how do we enhance motivation, right? That number 1 question, how do we enhance motivation? And certainly we know that motivation is a key component to behavioral change, and it's actually related to frontal cortical function. And so we have things like motivational interviewing and CBT that we can be using. What about increasing attention and focus, so that again, young people can actually be paying attention to things and then hopefully being able to notice how they're behaving. And again, mindfulness-based approaches and DBT approaches are definitely falling in that area. And then I also want to talk about education, because we certainly know that knowledge doesn't change behavior. We know that from practitioners. We know that everywhere, right? We know that going into schools and talking about such and such a topic in public schools, has no shred of effect later on behavior. We know from sexual health programs in the U.S. where young people are basically just, their education strategy is, just don't have sex. They're just as likely to have sex later on, but they're much less likely to use condoms, right? So we know that there are really ineffective education programs, but we also know that there may be some things that can make education programs more effective. And to me, it really relates to what Ian Manuel was talking about, which is engaging young people, in understanding what might be going on and giving them some information. I can't tell them what to do. I always say to the teenagers I work with, I can't tell you what to do, but I can give you some information that might allow you to kind of make some decisions, right? And a great example, just a very quick story. I had a young man, or I just was sitting at my desk, which I rarely do, a couple of months ago, and the phone rang, and I picked up the phone, and this young man's voice said, Dr. Leslie, it's Dave, like I was supposed to know exactly, but I actually did know who it was, but anyway, so he just assumed, no, for sure. And he's like, yeah, I'm with a buddy of mine right here, and we had a question about ketamine. And I thought, that's so great. Like, he wants to find out. He's probably saying to his buddy, I've got a special in, I can get to the expert. But he was calling to get information so that he could share it and then hopefully use it to make a decision about something he was going to do. So I think really we want, teenagers, do need relevant information. Again, not that they're necessarily going to always use it, because we know they're impulse control and all of the rewards may take preference over the information. But I do think that education is something that with young people, may not be something that we've spent as much time on. So motivational interviewing. So there actually have been some studies trying to link how do we understand the effects of motivational interviewing and how do we understand it in terms of what we know about brains. And there was actually a recent sort of a systematic review that tried to look at all of the studies that have been done in adolescents using motivational interviewing, and they were able to find that overall there actually was a positive effect. It was small, but it was persistent, and it was definitely there that motivational interviewing does have an impact on adolescents' substance use behavior. Now, again, like I talked about, the challenge was how they defined MI. It wasn't always delivered in a rigorous sort of similar way. It could have been a single MI intervention. It could have been a series of meetings. So there was a lot of heterogeneity around how the motivational interviewing was delivered. Having said that, there still overall was a model. So we don't exactly know what's the best way to deliver MI to be able to kind of produce an effect. But we do know that there is some evidence that it actually has a positive effect. So I think that's important. There also are some studies looking at what happens to a young person's brain when they actually are engaging in change talk. So they did actually a really interesting study where they actually looked at change talk and counter change talk in adolescents. And then they scanned their brains with functional MRIs as they were eliciting that change or counter change talk and actually speaking it. And they actually looked to see what was happening in their brains. And they actually were able to show that change talk did elicit activation in areas of the brain that had to do with introspection and focus. So there is some evidence, in actual fact, the actual act of engaging in change talk does seem to be activating the areas of the brain that you want it to be. So I think that's kind of exciting, and that's very recent research from the last year. In terms of mindfulness, so the other, Alan Marlatt was really coined the sort of urge surfing idea, which is really essentially mindfulness, but I like this little cartoon around mindful or mindful. So we definitely, again, the research is quite promising in this area in the sense that there does seem to be the ability for mindfulness to actually be having some impact on the brain in terms of rewiring, in terms of being able to develop some changes in how the brain works. There have been a few little studies, not much. This is the only study I could find around looking at mindfulness specifically with adolescents. And it was sort of, I would say, it was sort of variably successful in terms of how it actually worked out with the numbers of young people. But they did look at motivational and mindfulness intervention with young adult female marijuana users up until their early 20s. And they were able to show some positive effects on use. And again, one of the skeptical sort of things, the skeptic in me says, it's great to do a controlled study where people are incentivized to come regularly, to come for the follow-up. They're in a study, 8 sessions, it looks great, right? And how does that work in the real world? But again, I think what we can, I think the value of this is that we can see that it can work. The question is now, how do you get creative in trying to kind of implement this in the settings with the young people that you have? So I think there's some really promising stuff, and so I think that we need to be keeping that in mind. So the education piece is the piece I'm going to end with, and then I'd like to kind of get some feedback and discussion going. So we know there's a link between perception of risk and use. And we've seen that. Remember I told you at the very beginning that tobacco use has gone way down and cannabis use has gone way up. And so we know that that's actually a direct influence of the perception of risk. So we definitely know that as perception of risk goes down, use goes up. And that's really what we've seen with cannabis, right? There's a huge perception in everybody that marijuana is not bad for you, right? That's not correct, but that's a prevailing sentiment in society, actually. And we've seen a direct result that's been having on young people, and not just young people, but people in the next age group up, in terms of rates of marijuana use. So we definitely know that there's a link between perception of risk and behavior. The question is, can we leverage this if we can increase the perception of risk, like's happened with tobacco? If we can do that perhaps with something like marijuana, can we be looking at reducing the behaviors associated with marijuana use? So this is kind of my other life because I do a lot of medical education. And so I actually worked with 2 really amazing medical students a couple of years ago. And we actually worked with young people to develop this resource. So we actually brought a whole bunch of information about the health risks of marijuana. And we brought it to a group of young people in our Substance Use Day program. And we said, which of these do you think teenagers would be most interested? Which of these are most important that teenagers should know? So we didn't want to have a program that had like 12 different health risks. And they helped us identify the brain effects, the effects of substances on your brain, and mental health, the risks of schizophrenia. So those are the 2 areas that they felt were most important for teenagers to know about. And so we developed this resource going back to them over the time to say, what do you think about this? Should we do this? What do you like about this? And so it was really co-created with a number of adolescents. And what it is, it's a sort of a 1-hour resource that can be done with a group of teenagers, and it really provides them a lot of information in a very interactive way. a lot of what I've shared with you, you can probably recognize one of the models. So we actually have used some of this research we've actually used in this resource. And we've actually piloted now, we've actually been doing, there actually is a perception of risk scale you can use. And so we've actually piloted this education resource with some groups of young people who are engaged in substance use treatment. And we were able to actually show a statistically significant difference before and after viewing, participating in the session in their perception of risk associated with marijuana use. Now, it's a small number, but we were able to show that they did actually perceive greater risk associated with marijuana use than they had before they watched the resource. And we just actually were excited. We just got some money to be able to now do a further evaluation where we're wanting to see is that perception of risk sustained over time, and can we see whether it might have any influence on their overall use. So it's just, again, just an example of, thinking about, is there a way that we can be looking at education in a creative and engaging way to be able to influence the perception of risk associated with behaviors in teenagers. So I'm just going to come back to what I was hoping to do. So hopefully you now have a little bit more of a sense about what's known about the impact of alcohol and substance use on the brain. And I've sort of just kind of brought to you some ideas about how this might inform some of the interventions that we are choosing to use with adolescents and their families. I'm just going to end. This is just a wordle of some feedback that we've had from some of the young people in our day treatment program. And sorry, I had a few quotes from them, but I guess it didn't make it into this session. So I'll stop there, and then what I'd really love your feedback is in terms of just thinking a little bit about what is it that you're using in your programs, or some of the interventions that you're using in your programs linked to some of these strategies that I talked about in terms of the MI, in terms of the mindfulness. How are you thinking about all of this? Maybe I'd like to kind of contextualize it for you in terms of the work that you're doing. Mm-hmm.
And kind of like riding that emotion or riding that wave, so that that sensation or that feeling will pass. You just have to ride it out and kind of get different ways to distract yourself. So that's to see the combination between substance use, self-harm, and how kind of put the DBT model that we did in the past year.
How are you finding that young people are, we're doing sort of similar things. We're doing it in the context of kind of yoga, actually, just because we found that if it's embedded in something else, then the sort of breathing, the mindfulness things kind of seem to be kind of accepted a little bit more. But are you doing it sort of as a sort of within the context of another activity, or are you doing it?
We kind of brought the mindfulness in other things where we talk and we kind of started with in our formal groups, in our formal groups, and now kind of spilling out into other parts of our program. And it's now becoming one of the main strategies for what we're doing, like defining strategies for clients about how to assert these emotions. They're using mindfulness and looking at ways for distraction, and also like really helping them to kind of acknowledge those feelings and recognize that they're feeling. First of all, get rid of they can distract and using the mindfulness as a distraction.
Right. And you've had good feedback from the young people who are using it?
It's kind of surprising how fast they pick up on it. Just a quick little story, we got formally started in November for our first session from November to February. And by Christmas, we had a little Christmas package here. I played Santa Claus and threw like a little DBT joke and like that. And I had 7 or 8 kids that were in the audience, like bunch of guys were running, and they were yelling out the term.
Oh, cool! Wow.
So within
yeah. So they'd internalize those ideas. That's great. Yeah. 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 That's cool. Yeah. Yeah, we have complaints from like even the big tough guys in our program. What, yoga's? We're not having yoga this Monday? Like they really like it. Other experiences in terms of people using some of these things, or kind of what you think about sort of the application of some of this?
We've done a couple of groups with our clients where we do some
sure how that was going to go over, but it was really well received. And one of the things that we did was explain the different executive functions and talk about how these are all skills we can practice and use. And that all of us have our strengths and weaknesses, and we develop the strategies to coach ourselves up in the areas that are more difficult for us. And we found that it really normalized for them a lot of the struggles that they had been having, like around, you know, motivation, impulse control, conflict resolution. They were able to see how those were learned skills that when they reflected on their own experiences, they hadn't really had opportunities to learn, and were quite motivated, I think, to think that they might be able to create opportunities to still learn those skills.
Yeah, so valid sounds like it validated kind of what what they're experiencing and gave them kind of something to kind of see that there's something they can actually target.
And it allowed us to talk about problematic, you know, behaviors in a way, like from a clinical, like as a clinician, where I felt like the language of judgment had been lifted out of it. So we were really able to talk about what was going on.
Cool.
Yes, that was well. And we also did some yoga. And we also got really slapped there from the training yoga instructor. So it's
So you
really
can, but you can maybe back it up by saying, and this is actually validated by brain research, right? Yeah, yeah, yeah.
So many talents,
I'm trying to do some more creative things.
exactly all this stuff.
Yeah.
But it isn't real. It's just very, very, you know, what Gates was doing yoga, like he does.
Yeah.
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 So it's great
Right.
to see it percolating elsewhere there. Yeah.
The other really exciting area, I just went to a presentation recently that actually talked about martial arts. And, you know, and people think, oh, why would you get a bunch of kids doing kind of like, you know, like fighting stuff? But it's actually not. It's all about impulse control and mindfulness. So I thought that was, you know, I think we're really interested in looking at piloting some of that with some of the teams that we see, because again, that probably, for some of them, it may be more appealing. Again, not maybe because they think they're going to be fighting, but at least you could get them in the door, and then hopefully engaging. It's all about respect and you know, and mindfulness and impulse control. So I think there's lots of exciting possibilities looking at that as a way to try to kind of introduce some of these things.
You know, a running program.
Cool.
And people, you know, may think that running is just going out and running, but there's a lot of discipline to running. You don't want to go too fast. And, you know, so they're learning to regulate.
You have to focus on your breath.
Focus on your breath.
Yeah.
You know, they might start off by just going as hard as they can, and all of a sudden they, you know,
you should be very self-aware.
So we have a coach who
Cool.
kind of teaches them to, you know, to pace themselves.
Yeah.
And so
That's
it's
great.
a tremendous amount of discipline that's involved in some of these sporting activities.
And there's some research. I saw a couple of studies that actually talked about if you actually pair both physical conditioning as well as the mental emotional practice, they're actually together, or actually you can actually show increased brain changes if you're actually doing both physical and kind of cognitive kinds of exercises and practice. So
you could run along the river, and you're doing a meditation as you're running. You see,
for sure.
You're combining. I call it kind of like a spiritual thing.
Yeah, because you got a nice rhythm with your feet going, so you can be focusing on the pounding, on the whatever.
So
Did you?
This is my advertisement.
Yeah, no, it's right. Hey, I run. I think running's great. Yeah.
It's interesting, like from an employment perspective, right? So we're not clinical at all, but we do work with youth who have fairly significant mental health issues. So what I find, and strictly an observation, is that some of our most successful young entrepreneurs are youth who have very successfully dealt drugs, taken a lot of drugs. So
Yeah, you know what? Yeah.
They're risk takers.
Well, they're risk takers, right?
Sure, they're,
A good entrepreneur is a risk taker.
But
Yeah.
when you ask them about any previous self-employed experience, they you talk about that. So that
the silver lining in generalizable skills. I think it speaks to you know, these kids are bright, right? Like there's lots going on for them.
As you were talking about concussions and not knowing the impact of that, I have a niece who's a hockey player, lots of several concussions, and then acquired epilepsy. Just at the time, 18, so she was into some drinking, and decided to take a year off before she went off to college, and just was on a self-destructive path of partying, which was really awful. But the saving grace was she kept her job at McDonald's, which is a great employer for young kids, and actually a couple of months ago got into a management position there, and that was it.
Yeah,
That
so she
was
had
what turned all of that around. So, no therapy or just that having a responsibility.
Yeah.
Was just a trigger for her.
And that speaks, I think, just to the development. I think some of what I think we do is keep young people alive until they're ready to get better. Like honestly, like not to diminish what we all do. We all do great stuff, but for some of it is, you just see that developmental. They get to a point where all of this behavior is getting in the way of things that they see other people doing, and then so I think again that doesn't mean we should stop doing what we're doing, but yeah, 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 absolutely. Oh, okay. I think we have time for maybe one more comment. Mm-hmm. Yeah. Mm. So yeah. Yeah. Yeah, we haven't. Although one of the things we've wanted to do, and I think we'll be trying to do, is actually looking at piloting this cannabis resource with some parents, right? Because again, I think there's, out there around us, it's not just parents that have attitudes around this isn't bad. There was a Lipton tea ad a few months ago that was on kind of streetcar stops at Toronto that said, "How about a little pot at work?" Right? Like, what an awful, awful ad, right? Talk about normalizing marijuana, right, in a place like Lipton tea. Oh my God! So I do think there's lots of work to be done. I think as healthcare, as providers, I think we have an obligation to look at what are the obligations we have at a public education level, or working with parents around kind of again some of this knowledge transfer around. So you have to be credible. You're not going to die if you smoke a joint, right? There's that balance between being credible, but actually saying, we have some concerning information about teenagers, and this wasn't around when you were smoking marijuana, and the THC concentration is that much higher. And so I think some of it is acknowledging, yes, you've been really fortunate. You've been been able to, to get where you are. Having said that, this is your child, this is their brain, and how can we work together to kind of try to figure out how they're going to be successful. So we haven't. We do parent groups, we do parent education, but we have been looking at trying to how can we bring some of this new evidence into both parent and kind of public education. Not yet, but we actually have just gotten some money where we're actually going to be, hopefully, we've got a facilitator guide. We're just trying to get it into a little bit of a format where we can use it. The Downside of High, which was a documentary done a couple of years ago, the producer has given us permission to use some clips. So we're kind of trying to get a new and improved version of it, and then it is going to be available, and we're hoping to make it freely available with the condition that people help us with the evaluation of it. So stay tuned, and I'll definitely try to publicize that.
So Karen, thank you so much, and it's so great to be able to look at this new science and how some of the practical work that we're doing, is making a difference in knowing how the brain actually works and how the brain works on drugs. So thank you so much.
Great. Well, thank you very much for participating. I'm happy to talk some more.